Hi guys, I'm Victor. Thank you for being here on my channel. Let's do a rapid review USMLE Step 2 CK. So CK wants you to know that in patients with liver transplant, there's like a lane of time since the transplant to help you to find out if there's a big infection or not. If the transplant is more than 1 month, is between 1 and 6 months or more than 6 months. So in this case, we have a question about a lady that have a liver transplant 2 weeks ago, and suddenly she has temperature, she got fever, hypotensive. Um, she got pulse elevated, so she probably is presenting a sepsis because their leukocytes are elevated to 28,000. So they ask you, which of the following is the most likely cause of this patient condition? So it could be acute cellular rejection, aspergillus infection, bacterial infection, cytomegalovirus infection, Epstein-Barr virus infection, hyperacute rejection. We have here hyperacute rejection and acute cellular rejection as an option. And then we have the lymphoproliferative disorder. So which one do you think it is, guys? Think a second. So the answer is bacterial infection. Bacterial infection. So why bacterial infection? Because in these patients underwent a liver transplant 2 weeks ago and now has right upper quadrant pain, high fever, hypotension, tachycardia, and significant leukocytosis, suggesting a sepsis due to ongoing bacterial infection. Infection continue to be the major cause of mortality and morbidity in patients who have undergone liver transplantation. The length of the time since the transplantation help to categorize the likely infectious organisms as follows. By example, if you have a transplant less than 1 month, the more likely is bacterial infection. Bacterial cause from operation complication, hepatic access, biliary leaks, wound infection, by example, or hospitalization, intravascular catheter infection, or external drain, something like that. Complication with the surgery in C. So less than 1 month, bacterial infection. So the next step is more than 1 month, from between 1 month and 6 months. So in this case, is that it is opportunistic pathogens like cytomegalovirus, aspergillus, Mycobacterium tuberculosis. This is the most frequently, at least from 1 month to 6 months after liver transplant. As a result, because you are on a high dose immunosuppressive medications, so that's why you're getting opportunistic pathogens. So the next one is more than 6 months. So if you have a liver transplant more than 6 months, so in this case, patients have like a typical community acquired pathogens, like the normal that everybody get, because you have immunosuppressant usually maintained at levels. So immunosuppression is not like that is not doing like that big cause. So you are at a highest rate than the general population to take like any kind of community acquired pathogens, not like a hospital pathogens. Another option was hyperacute rejection. It is relatively rare from a rejection due to an antibody complement mediated response. So HBO mismatch. That's an example. This outcome manifests less than 1 week after the transplantation. So that would present in a patient less than 1 week after transplantation. So another thing that CK wants you to know is a common variable immunodeficiency. So common variable immunodeficiency, they show you a patient with acute pneumonia, acute evidence of the acute pneumonia like cough, short of breath, leukocytosis, by lower load infiltrate, and recent history of the recurrent pneumonia, sinusitis, bloated diarrhea. And so, as I said, leukocytes Q, they are elevated or normal range, especially more elevated. But when you test the immunoglobulins, they're all slow, all slow. So they want you to know that patients have the leukocytosis are, but doesn't have immunoglobulin. So the questions could be, well, what is going to be the next level? So you have to quantify the or measure the amount of immunoglobulin levels, or there could be the question, how do you expect to be the immunoglobulin? So they're going to expect to be low diminution. So the common variable immunodeficiency, the pathophysiology is abnormal differentiation of B cells into plasma cells, decreased immunoglobulin production. So symptoms are onset classically and between the ages of 20 and 40, as early as puberty, recurrent respiratory infections as pneumonia, sinusitis, otitis, recurrent GI infection, by example, Salmonella, Campylobacter, Giardia, chronic disease like autoimmune, rheumatoid arthritis, thyroid disease, pulmonary like bronchiectasis, fibrosis, GI, chronic disease like chronic diarrhea, especially. So the diagnosis is you're gonna find immunoglobulin diminution, big amount of immunoglobulin G diminution or absent, and diminution of the immunoglobulin A and M. No response to vaccination. So the management is immunoglobulin replacement therapy. So common variable immunodeficiency is the most common primary immunodeficiency in adults, and is characterized mainly by decreased susceptibility to bacterial infection. Recurrent respiratory infection like pneumonia, sinusitis, otitis, and gastrointestinal infections like Salmonella, Campylobacter are common, and they later may lead to episode of bloated diarrhea. So chronic giardia may occur, but opportunistic infection like a Candida or Pneumocystis jirovecii are very rare. Other characteristics of a common variable immunodeficiency include concomitant autoimmune disease like hemolytic anemia, rheumatic arthritis, pernicious anemia, inflammatory bowel-like disease, granuloma development, and increased rates of non-Hodgkin lymphoma. It's good to know that this disease is a sporadic mutation. It's not like a familial history. The diagnosis is made by quantitative measurement of immunoglobulin levels. Quantitative measurement of immunoglobulin levels.